just explain about facial transplantation? Is this very similar to a Tom Cruise film?
Face transplant is not without a lot of risk. It's like any other transplant. You have to take immunosuppression. It's either you get another face or you're going to get really bad scarring.
How far has plastic surgery come to resolve or help those?
Scars are particularly challenging. We can regrow skin in terms of the spray skin. The biggest thing, and I think this is pretty common for all of plastic surgery, is managing the patient's expectations and being clear about what you can achieve and what you can't. Your skin is your barrier to the bacteria that are outside the body. Now, we even have bacteria on our skin that's normal. But when you have a burn, you lose that.
Hello and welcome everyone. This is Dr. Amir Khan, your host for Khan Klinics, powered by American Muslim Today. My today's guest is an esteemed, accomplished person in plastic surgery. We're going to be talking about plastic and reconstructive surgery. My guest, Dr. Gayle Gordillo. She is a professor in plastic surgery at the University of Pittsburgh. She serves as the Senior Medical Director in Wound Services, Pressure Injury and Outcomes at UPMC Health System. Her research primarily focuses on chronic wounds, burns, diabetes-related complications, and innovative reconstructive techniques. She has extensive experience in management, especially difficult wounds, including those related to diabetes and leg wounds. In addition to Dr. Gayle's clinical roles, she has been continuously funded by NIH since 2005. She had contributed significantly to the understanding, treatment of complex wound, including development treatments for conditions like hemangioma and facial reconstruction. Her work on wound healing and pressure injury is recognized globally, and she has leadership positions, including President of Plastic Surgery Foundations. Dr. Gayle, welcome to the podcast today.
Amir, thank you so much for having me on the program. It's an honor to be here.
Pleasure to have you, ma'am. Now, before we go on to discuss your role and your accomplishment, we want to, for our audience, play a little video about plastic surgery, reconstructive surgery, and just differentiate that from cosmetic surgery.
Plastic surgery is all about using plastic to make people look pretty, right? Know and never repeat those words. The word plastic comes from the Greek word plastikos, meaning to mold, a reference to how plastic surgery is involved in the reshaping and manipulation of tissues. Generally speaking, plastic surgeons focus on soft tissue, such as skin, muscle, and fat, rather than bones, which are in the territory of orthopedic surgeons. Plastic surgery is far more diverse than what you probably expect. The public is most familiar with aesthetic or cosmetic plastic surgery that has been popularized by celebrities and showbiz. But the overwhelming majority of actual surgical procedures in plastic surgery are reconstructive in nature. In 2018, there were 5.8 million reconstructive surgical procedures in the US compared to only 1.8 million cosmetic surgical procedures. That being said, non-surgical, minimally invasive cosmetic procedures like Botox or fillers are extremely popular. In 2018 alone, there were 15.9 million non-surgical cosmetic procedures. So what's the difference between cosmetic and reconstructive plastic surgery? Cosmetic plastic surgery includes procedures involved with enhancing one's appearance. The most popular cosmetic surgical procedures include breast augmentation or boob job, liposuction, rhinoplasty or nose reshaping, blepharoplasty or eyelid surgery, and abdominoplasty or tummy tuck. The most popular cosmetic non-surgical procedures include Botox injections, soft tissue fillers, chemical peels, laser hair removal, and microdermabrasion. Reconstructive plastic surgery is highly diverse, and in my personal opinion, far more fascinating. Recon includes surgical procedures to correct facial and body abnormalities that can be caused by birth defects, like cleft lip or cleft palate, injury, like soft tissue reconstruction for severe traumatic injuries, disease like breast reconstruction after mastectomy for breast cancer, or aging. Plastic surgery is on the cutting edge of innovation in medicine, with radical procedures like face and hand transplants, or even gender reassignment surgeries that are so convincing you wouldn't believe it.
That was quite good, showing us a little bit of differentiation between how plastic surgery, reconstructive surgery differs from just general cosmetic surgery. Our first question, Dr. Gayle, is about what are the challenges that you think one faces treating patients, especially burn patients we're talking about, when they come to you?
Yeah, the biggest thing, and I think this is pretty common for all of plastic surgery, is managing patients' expectations and being clear about what you can achieve and what you can't. And when I take care of burn patients, one of the things that I try to do is lay out the trajectory for them. Particularly for a big burn, there's an acute phase where they're really sick and you just want to try and keep them from getting infected and getting them stabilized. There's a reconstructive phase and there's a rehabilitative phase. The big thing is the patient has to accept that there is going to be pain that you push through to come out to the other end. And understand that there is this fairly long process for a big burn. A smaller burn, different story. But even with a smaller burn, burns are very painful. And just accept that there's going to be some pain. And of course, we're not trying to minimize that you have pain, and we do want to treat it to the best of our ability. But it's generally impossible to take all that pain away and to go through all the dressing changes, the physical therapy, the strengthening and range of motion just to get out to the other side. So that's a big thing, is managing patient expectations. And then, of course, what resources do you have? The biggest thing to me is you need good people to take care of these burn wounds.
So after you've assessed the acuity of a burn patient, and that is whether the burn is first degree, second degree, third degree, you go on not only assessing the patient, but you're assessing what is the social support around the patient and what sort of psychological, physical, other core factors are that going to help you be successful in eventually controlling the outcome. You mentioned just briefly about infections. What sort of infections are we looking at, and how are they important in a burn patient that presents to you?
Yeah, so your skin is your barrier to the bacteria that are outside your body. Now, we even have bacteria on our skin that's normal, but when you have a burn, you lose that. And so you're very vulnerable to infections. And 30% of people in the United States, just walking around day to day on the street, 30% have a bacteria called MRSA. Methicillin-resistant Staph aureus, or MRSA. That is a particularly challenging bacteria to treat. There are very few drugs that work on it, and it can easily overwhelm a patient's immune system, especially when they're burned, because they are immunosuppressed due to this if they have a large injury. So that's one that we're very worried about. And there are others that are out there, particularly if a patient's in a hospital setting where another patient could have it, and it could easily get transmitted. So infection is for sure one of the other very big ones, and there are some pretty challenging bacteria to treat. As we gain more and more sophisticated antibiotics, the bacteria develop ways to escape killing by those antibiotics. And so it's a cat and mouse game.
Absolutely. Dr. Gordillo, you've mentioned in your work and emphasized about the need of early intervention strategies to manage burn patients. Would you mind just elaborating and explaining a few of the strategies that you use to make sure your burn patient's outcome is good?
Yeah. So one is having them seen by an appropriate burn expert if there is a significant risk of complication. Mm-hmm. So what kind of burns are those? So things where there is a significant risk of life-threatening complications or long-term complications, they need to see a burn expert. Infection is obviously a big one, so we have to be able to clean the burn wounds. And like I said, many times you need somebody to help you do that, and then the dressing becomes really important. Again, psychosocial is a lot. A lot of times these patients they may be homeless. They may have substance abuse problems. Well, certainly when that's a situation that there's significant social risk factors, we may admit a patient that normally we would send home. So you really have to take in the totality of the patient's lifestyle and support system when evaluating these patients.
Let's talk a little bit further about the treatment options here and about grafts in general. What is a graft? Why is it important in a management of a skin patient? And what does a graft or skin graft versus a bioengineered or other graft mean?
So a skin graft is typically when we take the patient's own skin and we will mesh it. So we run it through a mesher in the operating room to expand it. And you can mesh as high as 6:1. So if I take a 50 square centimeter piece of skin, I can expand it to cover 6 times as much area.
That's pretty impressive. That means that you're taking a smaller piece and you magnify it or enhance it 6 times to
Correct.
cover the burn.
And typically you have to do that when somebody has a large area of burn, so they don't have very many donor sites. But the other thing that you can do is you can also convert those. You can take the skin and mince it and sort of solubilize it and spray it on.
Interesting.
So that will make it even go farther.
Fantastic. And that's allogenic keratinocytes, fibroblasts that's seeding into the matrix. Cellular-wise, these are substances that are help promote healing of a graft. Would you explain a little bit about that to us?
Yeah, so the things that are most important for a graft to heal are blood supply. So you have to make sure that all the burned tissue is excised because it's dead. So if you have to get all of that tissue removed, it has to be an adequate wound bed with a good blood supply. You have to immobilize the grafts so they don't get shear or rubbed off. And then you have to keep them from getting infected. So we usually will put some kind of topical antibacterial dressing on top of the skin graft to keep it from getting infected until the skin can regrow and provide that protective barrier.
And explain to us talk about the burns and regenerative medicine. How do you approach if you have a very debilitating scar? You mentioned it affects the joints, affects the neck and other parts of. Where has plastic surgery, how far has plastic surgery come to resolve or help those patients?
Yeah, so that's a great question. Scars are particularly challenging. We can regrow skin in terms of the spray skin and really sort of make it go farther than it has before. We can use certain scaffolds or dressings that will stimulate the formation, the wound bed to support skin. So it may not make skin grow per se, but it'll give you the necessarily vascularized bed that we talked about to let the skin migrate across and heal. Those have been out there for a while. What's new is trying to get the body to make skin or to regenerate that bed by itself. We're not there yet. We can do some things, but for burn scars, we're not there yet. But we can, believe it or not, make blood vessels. So we can stimulate blood vessel formation. We can stimulate islet cell formation to make insulin. So some parts we can. The skin cells, we probably don't need the body to make new skin cells because it will automatically. If there's a wound, it's gonna want to migrate across. The bigger question is, what are the barriers to that skin migration? And in my mind, those tend to be primarily adequate vascularized wound tissue and then infection. It's despite it seeming relatively superficial and straightforward, the actual regeneration of new skin without scar, we're still lagging behind.
So what we are saying here, that the scar tissue, which should not be forming any skin itself, we have now tools or looking into approaches that is able to regrow back skin over it, around it, or in it.
So it's a good question. If you're talking about regenerative approaches, Typically, you're talking about a scaffold that is going to allow the skin to migrate across. Now, what doesn't happen with those is the skin actually has, as shown in one of those slides, there's the actual skin cells, there's a cell type called fibroblasts. That's what gives your skin that elasticity, the ability to pinch it and have it flatten out again. So if you just have epithelial cells or epidermal cells, it doesn't have the same supple, elastic quality, and that's what we see with a scar. So getting it to regrow exactly how it was and not as a scar, nobody's there yet. It's the holy grail. The only time we ever see it is in fetal wound healing. So if you were to operate on a baby in the mother's womb, you can operate and there's not a scar if you're operating in the second trimester. So that's the only time we've ever been able to achieve that.
Tell us that's not happening now.
It does, actually.
Astonishing.
So for some defects like, and this is what pediatric surgeons do, but for things like diaphragmatic hernias, so where the contents of the abdomen is up in the chest for the baby, and that's a life-threatening condition, they may fix that. They can fix split in the spinal column. It's called the neural raphe. Sometimes they can do that. So for things like kids who are born with myomeningocele, they can try and repair that. Now, you can do that once they're born, but you do it in the first few days. But diaphragmatic hernia is probably the one I'm most familiar with. But again, you're venturing a little bit outside of what I do.
No, I understand.
But then there is in utero surgery being done.
But you're interacting with them, and then you're hearing stories about that it's particularly interesting to our audience. We're talking about now science that is going into a baby who's in development and trying to fix some things. And just for my audience, diaphragmatic hernias is generally something that exists between the chest cavity and the abdominal, and part of the abdomen protrudes into the chest or may, and as a result the heart won't develop or the lungs won't develop, and it's occupied some space. So our aim is to push it down and let the baby have those lungs, have those heart, and that's very critical. And we hear about stories that's going on. What that leads us to the next very interesting question, Dr. Gordillo. You've mentioned and talked a little bit about stem cell, and all of us are very intrigued, and I'm getting some questions on that. Stem cells and burns, how does that, or stem cell and just scars, or where do you find stem cells' role in plastic surgery now?
Yeah. So stem cells are an exciting concept, but the reality is they're a very small percentage of the cells in our body. Most of them will originate in the bone marrow, and they have to traffic or hone to the site where the injury is and assume whatever cell type that's needed at the site. And so if you try and just harvest those stem cells from the bone marrow and inject them into that site, so skip some of the steps, typically the rate of success of those cells surviving is about 1% to 2%. Not enough to really accomplish much. And you can't control the fate of those cells. So stem cells are risky. So when I say you can't control the fate, they could become malignant. They could become something you don't want them to be, like bone when you're trying to make muscle. So it's very tricky. And if you want to take those cells from a culture dish in a lab and reintroduce them into a patient, they're still viewed as foreign. Even if they came from your own bone marrow, you took them out and you grew them in a culture dish. It's not the same when you try to put them back in. So one of the things that our group is working on is a technique called tissue nanotransfection, where you find out what is the physiologic need. And I mentioned blood supply. So the very first paper that the group published was on a mouse model where they cut off the blood supply to the leg, and the leg should become gangrenous and die. and they touched it with a chip. And this chip is it's like a rectangle with multiple small needles coming out the bottom, kind of like a hairbrush.
Wow.
Except for it's a chip. And those little needles are nanometers in diameter. So there's several that will puncture the cell membrane and deliver cargo. So if your body needs blood vessels and it's deprived of the blood vessels, it's going to send out signals, I need blood vessels. What we put in that chip is what are called transcription factors, which turn on genes to make blood vessels. And I tell people it's like dropping a pebble, and then once the body gets the signal, there's an inability for the body to generate that signal. But once you generate that signal, it will amplify it. It will send it out across the site that's ischemic without blood supply, generally through particles called exosomes, and tell the cells in the area to turn on and make blood vessels. So that is different than stem cells. You are responding to the body's own needs and just giving it a push, and then it will regenerate. So theoretically, it shouldn't make blood vessels because we tied them off. But when it needs it, you can tell it to do it. And so that's the approach that we're taking to regenerative medicine. We can do the same thing to make pancreatic islet cells. And interestingly, when they make those cells, if you use that chip, the cells that get targeted to make the islet cells are actually in the skin, and they're considered stem-like or plastic in terms of they can become other cell types. And what we're really focused on in our lab is looking at how cells can become other cell types. It's not just through stem cells. So macrophages have that ability to do that, which is one of my papers. They can become blood vessel cells, and fibroblasts can also become blood vessel cells called endothelial cells. So we're trying to move past stem cells, which are inefficient and uncontrollable, and just use the body, to help the body do what it would normally do, but for some reason it lacks the signal. We just put the signal in and it turns on.
That's amazing. It really is. When you describe this, you take us to another world. So we really appreciate just for our audience, it's a fantastic insight, because we're now we're imagining which way science is going. And if we are saying we are regenerating blood vessels, we are basically saying we're giving life to an organ. And essentially that's what it is, because blood takes life and then it takes cells, and then it identifies, and then it regrows. So that's a fantastic insight. One of the few questions that are coming up is about facial transplantation. And Dr. Gordillo, you've done quite a lot of work in this area, and our audience is a lot of them are women. First of all, just explain about facial transplantation. Is this very similar to a Tom Cruise film? Can we be transplanted? Is that what's happening here? And can the women change their face to whatever they want to? Is that where we're headed? So just tell us a little bit, and then we'll talk about the role that you're playing in actually severely facial disfigured women and helping them.
So face transplant is not without a lot of risk. It's like any other transplant. You have to take immunosuppression. By far, the fear is that if you have a rejection, what happens, right? Because you're going to get another, it's either you get another face or you're going to get really bad scarring. And this is still fairly new. There have been about maybe 30. It's not a large number of transplants that have been done. So this is not a common procedure.
But Dr. Gordillo, tell us it's happening already, right? It's
happening.
Yeah,
oh yeah, it's happening. There are a few sites in the United States that do them, and there are sites across the world that do them, but none of them are doing a lot.
We understand that. Okay. So you're saying there's risks involved.
Big risks, and the surgery is very complicated.
It's the same like when we transplanted lungs in the beginning, or kidneys in the beginning. There were a lot of issues. And now kidney transplant is different. Same as with lungs. Lungs, we've come a long way. Heart, we've come pancreas, like you mentioned. So what entails a facial a little bit? Just a few words about it. We're not going to get carried away here. But and tell us where its real role is.
So for the patients that they can't swallow, they can't control their secretions, they can't go. They're so disfigured they can't go out in public. Many times, these patients can already be blind because they've had whatever injury they've had to their faces affected their eyes. They're so disfigured they can't go out in public, and their quality of life is terrible. But you have to replace what's different about. I mean, nobody looks at your kidney. You look at your face every day. So you have to have muscles that work, bones that work, nerves that work, blood vessels that work. It's extremely complicated. And the other thing is, when it comes to rejection, the skin is the most antigenic organ in the body. So it's very difficult to control rejection in skin.
Thank you for that answer. 3D imaging, reconstruction, using the current imaging tools. Would you kindly explain how is that helping plastic surgery?
Yeah, so and a face transplant is one example, but military, any kind of gunshot wound to the face, severe trauma or cancer defect, when you want to reconstruct the jaw or anything in the face, you're usually trying to achieve symmetry. And so we can take CT scans, if it's going to be a cancer operation, before that part of the jaw or face is resected, and create, if we reconstruct them and we bring bone up there, we need to fix the bone with plates and screws. And so we can pre-bend the plate to achieve symmetry with the other side, and then we can cut the bone in the operating room to align with the plate, and then just put it all in block, and it saves, it's much safer in terms of the reconstruction. It saves time. It gives you a better result. That's the beauty of what's called virtual surgical planning.
Excellent. Can I ask you about another area that I'm seeing a lot of interest and a few questions coming in, people being, some being optimistic and some being pessimistic about it, the role of AI in plastic surgery. How is that coming along? And give us a few examples. Our audience is very interested in knowing, is it going to bring about a big change? And how is it affecting the plastic or reconstructive surgery work? I'm keep on telling my audience the same thing. They keep on getting it into, they're getting it confused still with a little bit of cosmetic surgery and the lips and the eyes and the face and
I guess if I were to think about how we might use AI, it's pretty common for plastic surgeons to take pictures. And there is software out there that will say, you should advance the chin to get better facial harmony, and look at the underlying bony structures. And that is a reconstructive procedure. So you can use that to identify approaches that are going to get you the best outcome. Like, you should move the chin. You should advance the chin 5 millimeters forward. Now, we do that right now sort of by hand, I guess. And the other big thing that I would say is most of these measurements and sort of norms are for Caucasians. So particularly when you're talking about ethnic norms, having something like a machine learning or an AI that's seen a lot of these is going to give you better advice in terms of how to achieve a more aesthetically pleasing result with your planned surgery. So we talked about the virtual surgery. Essentially, it's going to help guide you without the whole plates and screws and filling in a defect. That's certainly one way. Another way is that when we reconstruct things, there's typically many ways to skin a cat. An AI approach might say, well, here's all the options, and given these 10 different options for a flap, in this patient, this may be your best choice. Now, we're not there yet, but that would be one thing that might come along.
So there is a role for AI to play in plastic surgery, and a follow-up question to that is, how much of role is robotics playing in plastic surgery and reconstructive surgery, whether it's your burn patients, diabetic patients, or chronic wound patients? Is there any role, and what's out there?
Yeah, so robotics are great for places that are difficult to access. So there is a surgeon who's doing reconstruction, if you think about it, at the back of the throat or the base of the skull, where you can use a robot. You literally don't have to get your hands in there. So it's a space that's hard to get to, and they do require reconstruction sometimes. And that's how you would use a robot in plastic surgery. Most of the other things, it's when we're making a breast, we're not going to use a robot. When we're reconstructing a lower extremity, because we tend to be more on the surface, but when it's inside and it's hard to get to, that's where a robot comes in handy. So base of the skull, intraoral stuff, tends to be where you would see it.
Dr. Gordillo, there's a very big issue of diabetes and how chronically debilitating their skin scars are, and they are notorious of their healing process is very, very painful, very cumbersome, prolonged and protracted. Tell us what your research has been in this area.
The healing in diabetics is compromised for multiple reasons. One is high glucose makes it difficult for the macrophages, which, if I were to describe that's like the Pac-Man inside your body that cleans up the wound site and then helps you heal. Those are impaired with diabetes. And then you'll frequently have blood flow issues. You'll have nerve issues, so you do need some nerve innervation to facilitate blood vessel repair and regeneration as well. And then the big one to me is infection. And most of these wounds, by 1 month, they have a type of chronic infection called a biofilm infection, but there are no clinical tests to diagnose it. If your skin is leaking water, the likelihood that you're going to recur, depending on how severe that leakiness is, goes up, definitely correlates well with that water loss. So it looks like the skin is healed, but it's leaky and defective. So it's not able to do its job, and then the wound comes back.
And you've also discussed the role of oxygen, hyperbaric oxygen, and for my audience, it is giving extra oxygen. Some people have chambers, and players and athletes are using this a lot. You're using it to heal diabetic wound healing. Explain, how is that working?
Sure. So in order to kill bacteria, you have these cells in your body called neutrophils. They're like cousins to macrophages. And they will release what are called reactive oxygen species. So if you think of, and those can kill bacteria. So if you think of reactive oxygen species like, or neutrophils like the gun, oxygen is the bullet. And you got to give them oxygen to make these reactive oxygen species to kill bacteria. Many times the source of oxygen normally is from the blood vessels and the blood flow to that area. But if that is compromised, which it frequently is with diabetics, then the neutrophils can't make those reactive oxygen species, and they can't clear bacteria, they can't clear dead tissue, and you can't heal.
Promising, very, very promising. We're going to come on to the last bit of the section and talk a little bit about an area that is particularly close to me and to a lot of other people, and that is hemangiomas and facial deformities. Tell us a little bit about first of all, about it, how the blood vessels, you described how the blood vessels, when they are less, you regrow, but what about when the growth of the blood vessels is too much? How are you controlling it?
Yes.
And then explain to us a little bit about the work and advancement that's done in that area, please.
So that's a very good description, that these are excess blood vessels that children, they develop when the children are initially born. So they are the most common soft tissue tumors of babies. Most will go away, but and about 10% will threaten the health of the child, either by obstructing the nose, the mouth, the eye, the throat. So about 10%, there's an urgent need to treat them. We can't just wait for these to start to go away by themselves. But there's still some that don't respond, and there's still some risks with that. So my goal was to try and find some alternatives to help treat these. And one, my most recent paper, We talked about the tissue nanotransfection where we deliver the cargo and it makes blood vessels. Well, the tissue nanotransfection can be used to deliver cargo that makes these angiomas go away. So if I do it for 1/10 of a second, at least in my animal model, if I do it for 1/10 of a second, touch the skin twice a week, it completely goes away. And so that's one, and we have an identified cargo. So that cargo is called a microRNA 126. That is typically a signal to drive blood vessel growth. And so if you block that and tell it not to make blood vessels, they go away. So that was, in animal models, 100% cure. So the endothelial cells, the excess endothelial cells die. The normal endothelial cells don't die, just the ones that are really hyperactive and reproducing. So that's one that I'm really excited about and hope to get to patients soon.
Dr. Gordillo, very inspiring, very enlightening. So thank you very much for being with us. We wish you the best.